It's a great pleasure to talk about our recent work. The title of my talk is Associations Preoperative Variables of Ipsilateral Hip Abductor Muscles with Gait Function after THA. THA is an effective treatment for hip osteoarthritis. Postoperative functional improvement occurs within the first 6 months. However, 10% of patients report dissatisfaction after THA due to insufficient improvement. It remains unclear what preoperative factors are associated with functional limitations after THA. In OA patients, the gluteus maximus, the gluteus medius and minimus are significantly smaller in the affected limb than those in the contralateral one. Fatty infiltration is observed with minor fatty infiltration in the gluteus minimus in end-stage hip OA. However, it's still unclear how hip abductor composition affects functional outcomes after THA. The aim of this study was to evaluate preoperative variables hip abductor muscles of the operated limb and elucidate the association with gait function after THA. Of 172 hip OA patients with THA, we excluded 130 patients based on the exclusion criteria shown here. Resultant 42 patients were included in this study. Mean age was 70.9, mean BMI was 22.8. THA is performed through a lateral approach with modified Mossardi technique for minimal damage to the hip abductor muscles. The same rehabilitation protocol was provided for each patient. Gait speed, TUG, ipsilateral hip abductor strength were measured as functional outcomes. Total muscles were automatically segmented based on CT densities of -29 to 150 Hansfield units by the software. Cross-sectional areas of LLM, LDL, and MFAT within each TM were measured by CT software as the areas of pixels according to the definition by CT densities indicated here. IMAT was calculated as summation of LDL and MFAT. Muscle composition was evaluated by CT taken for preoperative planning within 2 weeks before THA. Muscle composition of the glutei medius and minimus and the upper portion of gluteus maximus was analyzed on a single CT slice at the bottom end of the sacroiliac joint. This table shows preoperative muscle composition of the glutei medius and minimus and the gluteus maximus. This table demonstrates preoperative and postoperative functions. Gait speed, TUG, and hip abductor strength after THA significantly improved compared with preoperative data. Pearson's correlations were analyzed between preoperative muscle composition and gait function after THA. LDL, LDL per TM, and IMAT of the glutei medius and minimus correlated negatively with postoperative gait speed and positively with postoperative TUG. TM, LMM, and LMM per TM of the gluteus maximus correlated positively with gait speed after THA. MFAT per TM and IMAT per TM of the gluteus maximus correlated negatively with gait speed after THA. Postoperative TUG correlated negatively with LMM and LMM per TM of the gluteus maximus and positively with MFAT per TM and IMAT per TM of the gluteus maximus. Pearson's correlations were also calculated between preoperative clinical data and gait function after THA. Age correlated negatively with postoperative gait speed and positively with postoperative TUG. Preoperative gait speed correlated positively with postoperative gait speed and negatively with postoperative TUG. This table shows the results of stepwise regression analysis using the significant variables. From regression analysis using the 10 significant variables for postoperative gait speed, Tm of the gluteus maximus was selected as a variable that explained 20% of gait speed after THA. Regression analysis using the 9 significant variables for postoperative TUG showed that LDL of the gluteus medius and minimus was identified as a variable that explained 26% of TUG after THA. Tm of the upper gluteus maximus was found to be the explanatory variables of gait speed after THA with positive correlation. In contrast to the lower gluteus maximus, no significant alterations are observed in the upper gluteus maximus that works as a hip abductor in hip OA. Ipsilateral gluteus medius and minimus are smaller in patients with unilateral hip OA than healthy controls with contralateral hip abductor. Taken together, the upper gluteus maximus with no significant atrophy could play a critical role in gait speed after THA. LDL of the gluteus medius and minimus could be associated with TUG after THA with positive correlation. IMAT in the hip abductors correlated with poor balance and mobility dysfunction in older adults. Fatty infiltration in the gluteus medius is constantly observed in end-stage hip OA. Minor fatty infiltration within the gluteus minimus is also found as a result of normal aging. Therefore, increased LDL in the gluteus medius and minimus as a part of IMAT likely has a negative influence on postoperative TUG. So in conclusion, this study has provided the first evidence that the cross-sectional area of the upper portion of the gluteus maximus and the area of low-density limb muscle in the gluteus medius and minimus of the affected limb before THA are partially associated with gait function after THA. So thank you for your attention.